So you'll be
Thank
talking
you,
about.
Dr. Divya, and thank you, the team at Tony Fernandez Eye Hospital, as well as Dr. Rashina and Dr. Mini for giving me this opportunity. My talk is on golden hour management of central retinal artery occlusion. And as you all know, central retinal artery is a branch of ophthalmic artery which arises from the clinoid segment of internal carotid artery, and it is one of the first branches. Usually it arises directly from the ophthalmic artery, or sometimes it can arise from the one of the long ciliary arteries, medial or lateral, and it supplies inner two-thirds of the retina. So pathophysiologically, most 85% of the causes of central retinal artery occlusion is embolic. That is the most common cause, either from a carotid artery plaque or from a cardiac source. Rarely it can be due to thrombosis associated with systemic vasculopathies. It can be due to inflammation, mainly giant cell arteritis, and other rare causes like hypercoagulable states and vasospasm. It's very important to recognize this emergent condition, and when it presents, it usually presents with a painless severe monocular vision loss, and patient might complain of a curtain falling down in front of his eye. And ophthalmic signs are unmistakable. You have the cherry red spot, which is seen in 85-90% of the cases, and usually there is a central retinal whitening, which is seen in about 70% of the cases. Rarely you can see an ampulla inside one of the arteriolar narrowing can be seen, and you can have box scarring of vessels, and 25% of the cases will show an optic disc edema also. So this is actually a picture from the multicolor. It's sometimes confusing. You may not appreciate the cherry red spot in this multicolor films compared to regular photography. So what is the golden hour concept? It's basically, it doesn't mean an exactly 1 hour or something. It actually means emergent nature of this disease. And the retinal ischemic tolerance is about 90 to 120 minutes from Dr. Here's studies, and before irreversible damage can happen to the photoreceptors and ganglion cell layers. And our aim is to increase the perfusion of the retina within this period as much as possible. But having said that, we will still try to improve the perfusion if the patient presents within 8 hours after a CRAO. So immediate management, this is one true ocular emergency. We don't have much time. A rapid history taking, precise time of visual loss is very, very important, so that we can decide whether to intervene or not. Associated symptoms, that's very important, because you have to always ask, especially in elderly people, for headache, jaw claudication, scalp tenderness, because giant cell arteritis is actually one of the even though rare cause, but most important cause for central retinal artery, which should not be missed. And relevant medical history. Patient may be already known atrial fibrillation on warfarin, and you do an AC paracentesis, and you may result in an hyphema, which can be more intractable than the original problem that the patient had. So a careful history has to be taken, and anterior segment and visual acuity examination, which usually has to be seen. And if the patient has history suggestive of GCA, giant cell arteritis, immediately do an ESR and CRP. And the biggest question that is asked is, do you have to do fluorescein angiography in all cases of CRAO? This is the gold standard for confirming a CRAO. There are certain definite findings which will tell you this is CRAO. This is one example where you see the leading edge of the dye. That is, in one snap, you will never see one part of the retinal arteriole which is filled and one part of the retinal arteriole which is not filled. This is because of sluggish and happens only in CRAO. So this, if you see, it's definite diagnosis of CRAO. Also, you can see the delayed venous filling, that is AV delay, which is also very significant diagnostic of CRAO. Having said that, it is not important to do when patient presents in an hyperacute state. We don't have time to do a fluorescein angiography. So most of the diagnosis has to be done without a fluorescein angiography clinically. But there are certain situations. In this picture, do you see a CRAO without a cherry red spot? Whenever you don't see a cherry red spot, I would prefer to do an angiography at least after the golden hour is over. Golden period is over. Here you can see that other than the features of CRAO, you have a choroidal filling defect in the medial side which is persisting. That is, the medial ciliary artery also is involved. So whenever the ciliary circulation is involved, you should suspect just more than an embolic CRAO. It could be a case of giant cell arteritis when this sign is present. Other situation where sometimes you do is you are not sure about the diagnosis. A patient who presented with sudden diminution of vision, history was very similar to CRAO, but when you look at the patient, he has 6/6 and 6 vision and there is no cherry red, few cotton wool spots. So the cotton wool spots are an alarming sign. It tells you that there is something going on in the retina. It's suggestive of global retinal ischemia, and you see there is a superior field effect for this patient. So when you do a fluorescent angiography, what do you see is that there is a central retinal artery occlusion. This is a central artery occlusion with 6/6 and 6 vision, because 6/6 and 6 vision is because patient has a very big cilioretinal artery which is patent. So cilioretinal artery, as you know from the ciliary circulation, that is not blocked by the CRAO. So that's why this patient has 6/6 vision. So all evaluation for a CRAO has to be done for this patient also. But OCT, coming to OCT as an ancillary test other than it is more important than FFA, mainly because it can be quickly done and it is one of the most diagnostic tests for CRAO. And it also has another advantage over FFA, it can predict the severity of the disease. Like in this case, this is one of those cases where you see the complete intraretinal hyperreflective. The inner retina becomes totally hyperreflective, and that tells you that there is a full thickness ischemia. That is pathologically there is non-arthritic permanent CRAO as well as non-arthritic transient CRAO. Permanent CRAO causes a complete opacification of the inner retina. This is prognostically poor. Other than this this is the most common sign that we see, and other than that you can see the widening of the outer layers. This is mainly because of as an artifact, and sometimes you can see subretinal fluid also. And these are other signs which you see. This is actually what is known as paracentral acute middle maculopathy or PAM. These are hyperreflective bands in the inner nuclear layer. In CRVO, this is a poor prognostic sign, whereas in CRAO, this is a good prognostic sign, mainly because it tells you the ischemia is mostly transient. Only the deep capillary plexus is affected. So this is probably transient. Vision might improve in this patient. Another sign is a prominent middle limiting membrane or PMLM, which is a hyperreflective line in the outer plexiform layer. That also tells you that the watershed zone is only affected in this. So these can be signs of transient non-arthritic CRAO. Other signs are inner retinal opacification. Sometimes you see this thing, that is a prominent retinal pigment epithelium. This is because mainly other areas are all hyperreflective inner retinal layers which are casting shadows. So under the fovea where you don't have ganglion, in CRAO the ganglion cell layer undergoes retinal edema. So that is why it becomes hyperreflective. So this area where you don't have ganglion cell layer, you see the RPE which is very prominent and hyperreflective. And sometimes you can have this internal limiting membrane shallow detachment, and also you can have in milder CRAOs or little after the hyperacute phase, you may see there is no hyperreflectivity, but still the inner retinal layers have lost their stratification. So that's also a sign of CRAO. So with OCT, we can diagnose most of the cases of CRAO, and also you can prognosticate. So the acute management strategy is to aim for reperfusion. It can be by dislodging the embolus or increasing the perfusion. You can increase the perfusion by decreasing the intraocular pressure. When the intraocular pressure reduces, the body pressure itself improves the perfusion of the retina. And the most important is you have to do this within the golden hour or the first few hours or first 8 hours. So the specific acute intervention that you would do is an ocular massage is the most non-invasive thing which you can do. It can be done with digitally or with a gonio mirror. You can press the eye for about till you see the arterial pulsations through the gonio mirror, and then release it so that this can dislodge the emboli. Or an anterior chamber paracentesis is a little invasive procedure, but can be done in the OPD itself. You can paint the eye with betadine and do a paracentesis and the slit lamp. And I usually put the patient flat supine or little head down in the chair itself so that the perfusion improves after patching the eye. And you can, after about 15 minutes, you can put the patient erect back and check for vision and remove the patch. Vasodilators also can be given, basically a nitroglycerin patch on skin patch or inhaled carbogen, that is increase the carbon dioxide concentration. So by asking the patient to breathe from a bag or something, so that the carbon dioxide is a vasodilator. You can give 2 tablets of Diamox. Hyperbaric oxygen, the idea is to increase the oxygen concentration in the blood so that the retinal perfusion improves. Thrombolysis is a thing which is controversial, intravenous as well as intra-arterial tissue plasminogen activator, but this can be only done if you have an interventional person in your hospital, neurologist in your hospital, right straight there. Because you cannot, by the time you refer the patient somewhere and then the golden hour is gone and only risks will be there. And systemic steroid is one of the most important treatment if you suspect GCA, because high dose steroid can prevent all the other treatment aim was for the affected eye, but GCA, when you see it is, you are going to treat the other eye, which also can become blind in a few days time. So this is actually a picture. I don't have the picture before when the patient presented. There was a significant retinal whitening. This is after paracentesis. I couldn't see any emboli at the time of presentation of the patient, but after paracentesis, you can see the retinal whitening has decreased. Now you can see multiple emboli. These are all the emboli which has got broken and moved into the peripheral vascular system. So you can see them multiple emboli, and FFA also showed reperfusion. So it is actually anecdotal. We don't have a definite evidence to tell that aciparacentesis will improve the vision in a patient, but we have, all of us have this kind of anecdotal cases where we have done aciparacentesis and the patient's vision has improved. So in patients with very low vision, you can always try paracentesis if the patient presents to you within that hyperacute phase. This is from a publication where they have showed improvement based on OCTA. They have shown the superficial as well as deep capillary plexus shows improved perfusion after doing a paracentesis. So this is a case actually where I want to highlight something. This is a 17-year-old man who presented to some other hospital with a loss of vision, and they had diagnosed CRAO at that time, and they had done a cardiac evaluation, carotid Doppler, everything. But what was missed was very crucial and very costly for this patient, because after 1 month this patient presented to us with NPL vision in the other eye. Here now you can see the retinal whitening, and definitely this is also at this time of presentation. We don't have the earlier picture, but here you can see the retinal whitening, which is very prominent compared to other eye, and there is no cherry red spot, and this 79 years. So this makes you suspicious of something non-embolic, and his ASR and CRP was very high, and he was positive for temporal artery biopsy, giant cell arteritis. So if you had been diagnosed at the first time, we could have prevented the other eye by giving high dose steroids. As I told earlier, his FFA shows there is a ciliary circulation also affected. The lateral ciliary circulation is affected in this patient. So that is the OCT also of this patient, which shows the PAM sign in the left eye, as well as you can see a skip PAM lesion here, as well as PAM sign in the other eye also. And it is not over with the acute management, because this is, as I told, central retinal artery is a systemic disease, and you have to find the cause so that we can prevent this happening again or in the other eye. So this involves a cardiac vascular workup, ECG to rule out atrial fibrillation, echocardiogram to look for any thrombi, and carotid Doppler for any plaques which is sitting in the carotid, Holter monitoring for paroxysmal atrial fibrillation, and blood tests should include all systemic diseases like diabetes, hypertension, and ESR and CRP is very, very important, as I showed with that case, and hypercoagulability states has to be done. Visual prognosis, if for the complete CRAO, that is a non-arthritic complete CRAO, it is a permanent CRAO, it is poor usually, but transient CRAOs can improve on their own. Complications are neovascular glaucoma. Unlike CRVO, this usually happens within a month's time, but it is incidence is very less. Recurrent CRAO, and there is always a increased risk of systemic stroke in these patients. So before I end this case, just one more case. This is not actually an acute CRAO. This was an young lady who presented with diminution of vision in both eye. And when you do the OCT, you can see the retinal thinning. There is no hyperreflectivity or anything of that you see in acute CRVO. This tells you there is an CRAO. Tells you that there is an old CRAO probably in this patient, and the retinal thinning and atrophy is suggestive of that. And when you do angiography, you see actually multiple separate vascular occlusions in this lady. You can see the large CNP areas and some neovascles that is happening. And on evaluation, she was found to be APLA positive, and she developed what is known as a catastrophic APLA right when she was under our treatment, and she died because of the complications from catastrophic APLA. So this is just to tell you the implications of systemic implications of identifying retinal artery occlusion, because she presented with to an ophthalmologist. So this is just an algorithm to go about how you manage a case of CRAO whenever there is a sudden loss of vision. First and most important thing is CRAO diagnose. Make sure it is CRAO. I had a case where one of my PG called me and told, sir, there is a case at night. There is a case which has come with sudden loss of vision. It is a CRAO. Shall I give digital massage? I told, okay, go ahead and give digital massage. He massaged the eye severely. And next day morning when I went and saw, the eye is almost crumbled and sitting like this, because it was actually a case of retinal detachment, and he had massaged it and it had resulted in 360 degrees. So retinal detachment, because of the retinal whitening that happens in retinal detachment, can be mistaken for CRAO. So first thing is diagnose, make sure it is a CRAO with clinical clues, and if we may use an OCT. And the next question is there a visible emboli? If there is a visible emboli, half your job is done. because you need not go to the other arm at all, because you know this is the problem is due to an emboli. Then it is managed as a CRAO. If it is in the golden hour, do the paracentesis and digital massage. If it is outside your golden hour, then do the carotid workup, ECG and all, so that you can prevent further attacks. But if there is no visible emboli, always do a CSR, ESR and CRP in the acute phase itself. But if it is beyond the acute phase, do an FFA also. And if ESR CRP is elevated, always do a temporal artery Doppler or a temporary artery biopsy. Temporal artery Doppler also is very sensitive. The halo sign which is present will tell you whether this is a case of GCA, and start the patient immediately on high dose steroid. The aim is to keep the dose without, it is high dose and it has to be kept at that level itself till the ESR of the patient comes down. It is not like in other cases, so that you prevent the other eye from getting the similar disease. And if there is ESR, CRP, FFA doesn't show anything suggestive of even GCA, always evaluate for hypercoagulable states in that patient with all these tests like SLE, PAN, APLA, all those conditions. So to conclude, it's a true ophthalmologic emergency. It represents always a systemic disease, and recognize the classic presentation and treat as early as possible. Never forget GCA as a cause of CRAO. And the message is act fast, think systemic. Thank you.